and it gives me great pleasure to introduce Dr. Nigel Trudgill, who's a consultant gastroenterologist in the West Midlands and currently chair of the BSG Oesophageal Section Committee and a member of the BSG Endoscopy Committee. And Nigel's talk will be on post-OGD upper GI cancer. Thank you.
Thank you very much, and thank you very much, David, for the invitation. Always a pleasure to come back to Sheffield, where I was born many years ago, went to university and was a trainee. I'm going to talk about a subject very close to my heart. I went to Japan 10 years ago and saw endoscopy and early cancer being dealt with in a very different way, and that inspired me to do some research which I'm going to share with you. Firstly, I'm going to share a case. This is one of our local GPs in Birmingham, and he encouraged me to share this case with people because of his experience. As you can see, he was 64 at the time I saw him. He presented with a dinophagia, and he'd had a couple of endoscopies in a different hospital over a period. The second endoscopy was because the nurse endoscopist who did the first endoscopy was concerned about the duodenum, but the consultant who did the second endoscopy said there was nothing wrong with the duodenum and didn't have any cause for concern, and recommended that the patient underwent relaxation exercises because he thought the chest pain excuse me, was stress-related. The GP wasn't happy with this, but took a while to convince a colleague to send him to a different hospital. And when he came to see me, you can see the endoscopic images on the right of the slide, and you can see a squamous cell carcinoma very clearly at the top of the slide. And when you add Lugol's iodine at the bottom, you can see that highlighted very clearly. And he had early squamous cell carcinoma. He had an EMR, but unfortunately he already had submucosal invasion by that stage and ended up having an esophagectomy, which was curative, fortunately. But he could have got away with endoscopic therapy if we diagnosed him earlier. So how often does this happen? This is a meta-analysis done by one of my previous fellows, Sian Menon, who works in Wolverhampton now. And as you can see on the left, about 11% of upper GI cancers are not diagnosed at an endoscopy up to 3 years before they're finally diagnosed. And the total world literature at that stage in 2014 concerned 2,000 cancers. And this occurred in about 1 in every 400 OGDs. So just a bit of terminology. Colorectal cancer that's not diagnosed within 3 years of a colonoscopy that doesn't diagnose cancer is called post-colonoscopy colorectal cancer. So there's no mist in it because that implies blame. And sometimes these lesions may genuinely not be there. For upper GI cancer, we adopted the same process. So if an upper GI cancer is diagnosed less than 3 years after an OGD that doesn't diagnose cancer, that's called POUGIC, post-OGD upper GI cancer. So we looked in a GP database called THIN, and you can see that we can massively increase the power, 2,000 in the world literature, and instantly we had 9,500 cases of upper GI cancer, and you can discern much more from that kind of level of data. And what you find is that POUGIC is associated with younger patients, particularly women, so 40% more likely to occur in women in this group. And if you look in the red box there, you can see that it's oesophageal cancer in women specifically that there's an issue with. A lack of alarm symptoms. And then at the bottom, you can see the kind of findings that were reported in these endoscopies. So people are seeing things, strictures, ulcers, esophagitis, gastric ulcers, but the cancer is not being diagnosed for some reason, even though there's visible pathology at the time. And you can see at the bottom that there's a failure of follow-up in some of these patients as well. So only half of patients with esophageal strictures or ulcers were followed up, and only 2/3 of gastric ulcers had any follow-up, even though they were subsequently diagnosed as having cancer. So some failures with our processes in endoscopy as well. We also looked at the same time in secondary care data, and this is data covering the whole of England for 10 years. So as you can see, you get 110,000 cancers in this group. And very reliably, the POUGIC rate is about 10%, and that's the figure you can take away with you. Can you see the same risk factors there? Female, younger age. This is slightly more common in gastric cancer than esophageal cancer overall. And at the bottom, you can see it was more common in proximal than distal esophageal cancer. So women, proximal cancer in the esophagus. This is squamous cell carcinoma that we're missing, and I'll go into that in detail in a second for you. Secondary care data also allowed us to look at other markers of endoscopy performance, and you can see a couple of them here. So if your trust wasn't very good at following up gastric ulcers, you are more likely to have cases of POUGIC, perhaps not surprising. And then second one down is if your trust had a high rate of missing or not diagnosing colorectal cancer, careful with my language, at colonoscopy, they also had a higher rate of not diagnosing upper GI cancer at gastroscopy. So there were failures of endoscopy practice in some of those units that need looking into further. And again, in the secondary care data, we found people were finding things, but they weren't making the connection with cancer, or cancer wasn't being diagnosed. So ulcers, strictures, ulceration. So let me just focus on squamous cell carcinoma a little bit for a moment. This is a big thing in Japan. And I just want to talk to you a bit for a second just to focus on this because it is really important in that female group. So smokers, people who drink a lot of alcohol, we know these things, past medical history of head and neck cancer. And what we want to do is we want to wash the mucosa very carefully, because if you look at that picture on the top column on the second on the left, that was blamed on Candida previously, and it isn't. It's squamous cell carcinoma, as you can see when you put the Lugol's on the picture below. Some of these lesions are quite subtle, and what you can do during endoscopy when you haven't got Lugol's is put the narrowband on. If you look on the bottom row, the third one from the left, that's what it looks like when you do narrowband. So the squamous cell carcinoma turns up brown or darker than the background mucosa. We've all got narrowband imaging. We can all look for this. If you've got an uncertain lesion, put your narrowband imaging on after you've washed it carefully and you'll see these lesions. So you're looking for something that's red or eroded or roughened. It doesn't look quite right. Maybe it looks like esophagitis, but in a funny place. And use your narrowband imaging and you'll find these lesions. The other thing I want to mention to you is this phenomenon of low prevalence expectation and satisfaction of search. These are radiology terms. So if you're reporting a radiology image in a young person and you're not really expecting to find something, you're less likely to find a serious abnormality. It's not a terribly good photo, I apologise about that, but if you look at the top right of the photo, you can see a little streak of esophagitis, and the streak at the bottom was also blamed on esophagitis, and this patient was referred to me for high-resolution manometry, similar to some of the patients Rami was referring to earlier on. And she'd been losing a lot of weight and had really bad dysphagia, and so I repeated her endoscopy because it seemed a bit of a strange pattern, and the little lesion on the left is an early carcinoma that was causing her symptoms. So just bear in mind that even though things are common, maybe that's not always the explanation for things, and don't be satisfied if it looks a little atypical. A few years ago, I was involved with a process led by Chris Raghunath and Andy Veach, trying to set some standards for upper GI endoscopy because we realised it lagged behind colonoscopy. And this document that was published in Gut a few years ago, I'd commend to you as the best summary we could come up with at the time. And I'm going to pull a few things out for you to help you with the quality of endoscopy generally and reducing POUGIC cases for you. So let's sedate our patients when we need to and use throat spray and sedation to make them as comfortable as we can. Use NAC and Infocol to cleanse, to get a good view, because we know from data that will give you the best possible view, either spraying it down for the esophagus or getting them to take a drink for the stomach. Let's take our time. So if we go slowly in Barrett's esophagus, we know from some data that we're more likely to see early cancers and dysplastic lesions. And the same is true in the stomach as well from Singapore data. So the slower you go, the more likely you are to find cancer and dysplasia. Don't rush. We know what we're looking for in the colon with polyps or polyps with invasive features, but we don't really generally recognise what we in the upper GI tract, either a Barrett's cancer, a squamous cell carcinoma, or a diffuse type cancer in the stomach. And we need our trainees, our nurse endoscopists, all of us, to know what we're looking for in the upper GI tract so we can recognise these images once we've cleansed and got a good, stable patient who's tolerating it well. So finally, we recommended audit in our quality standards. And I'm just going to show you this very briefly. Don't worry about the detail. Red is something that we could easily address. Blue is maybe acceptable. And there are three groups of people we need to focus on. Firstly, a pre-malignant lesion like Barrett's, which we're doing many of, where we might have a POUGIC case. The second is a focal lesion. I've shown you some examples of that, or a cancer-associated lesion. And then the next one is none of those features, but still POUGIC happens. And this is just some very brief audit data that literally my very industrious research fellow Dominic sent me yesterday to show you what happened in our trust. So we looked at 600 cancers and we found a POUGIC rate about 7%. And you can see the blue ones are probably acceptable reasons. So the biopsies were done, the surveillance interval for the Barrett's is appropriate, or adequate biopsies were taken from a focal lesion, but still POUGIC happened. We did our best, but something happened. Can you see that's only about 8 out of 40 cases. The other cases, there was all something wrong with the endoscopy. Not enough biopsies were taken, the endoscopy wasn't ideal. So we can do better. So just summarising. So this is relatively common, about 10% of cancers and 1 in every 400 endoscopies. Little quote, you see what you look for, you recognise what you know. So we need to know what the early cancer looks like to find it. And we need to learn the features of that. Please cleanse and take your time. And finally, root cause analysis and audit when you get POUGIC cases. Thank you very much.
Thank you, Nigel. So we've got a couple of questions on Slido. So one of the questions is that should Barrett cancers be considered as missed cancer if there was no obvious nodule 3 years ago and then subsequently picked up on surveillance?
It's a good question, and some series have excluded Barrett's lesions from this, but as we get better at endoscopy and we recognise more and more subtle lesions, those lesions are actually there. It's just, again, even in Barrett's surveillance, we're not recognising them, Rena. So yes, they should be considered. And it's analogous to the colon, isn't it, where IBD surveillance, that's quite a common reason for PCCRC. We just don't recognise the lesions well enough, but the lesions are there in those previous 3 years. So yes, it should.
Okay. Nigel, there's another question here. Is there any data on the incidence of HPV in squamous cancers?
There is some data, but not from our country, on HPV. And I think it is a genuine concern. Robert Logan is always a big proponent of this, isn't he? Because he believes that there's going to be an epidemic of pharyngeal and squamous cell carcinoma in the esophagus because of oral sex practices and catching HPV through that route. So there is some evidence worldwide of it, but not in the UK. So you can biopsy at the index scope. What we recommended in that document that I told you about from 2017 is that in LAC esophagitis and LAD esophagitis that we took biopsies and we followed them up. Awkward at the moment because of COVID, isn't it? But we should do that because I showed you in my data that quite a lot of those people will have POUGIC. A and B don't need a biopsy. So just the C's and D's, please. But you can do biopsies twice because that's more reliable, we know, from gastric ulcers.
Thank you so much.
Thank you.
Welcome.
That's brilliant.